Good afternoon, Chicago. I'm Dr. Allison Arwady, Commissioner at the Chicago Department of Public Health. Today is Tuesday, October 6th, and we are here to take your COVID questions. We're at a little bit of a different time today because there's been a lot happening. I actually came directly from a press conference that we did with the mayor announcing major new mental health investments. Very exciting. Obviously, with COVID, we've seen a real increase in terms of people who are having stress in their life. All of us have had our lives upended in one way or another, and we know that there are people who can really benefit from getting some additional support around mental health. And so today, as part of the Mayor's Framework for Mental Health Equity, which we had started work on prior to COVID, when the mayor had doubled the CDPH budget for mental health, and then when we got some COVID funding in from the federal government, we were able to direct some of that toward mental health resources. We were able to announce a new $8 million multi-year, $8 million each year investment to help increase mental health services for 32 existing community-based mental health providers. These are federally qualified health centers, these are community mental health centers, these are community-based organizations, and specifically they're in the community areas in Chicago that are highest need in terms of mental health, where we look at where there are low rates of people who are uninsured, where there are high rates of people who are needing transport for mental health crises, generally lower access. And so really exciting new investment, brand new for us to be doing major funding in this space. And we also announced some additional investments that, again, have built off a lot of the needs that we knew were here prior to COVID, but have been able to address even more thoroughly at the time of COVID, which is really to make sure that we're supporting people who have mental health or substance use concerns and are experiencing homelessness. And so we announced some new funding in that space. And again, it's all part of the larger framework where we are really trying to think about bringing resources into community where they are most needed to support people's mental health needs, and thinking much more creatively as a city about how to bring mental health to people who need it. We know especially people who may have some more serious mental health issues, who may have co-occurring substance use disorders, or other complicating factors in their lives, including living with homelessness. We know those folks often have difficulty keeping regular outpatient appointments. And so all along, we've been making new investments in outreach and science-based work to bring mental health out into the communities. And we announced some more work related to that. So that was really nice to be able to point to investments that are really needed, that are going where we most need them to be in Chicago. And it's another example. One of my and CDPH's biggest goals with our COVID response is first and foremost to make sure we are meeting the need today, right now, making the decision for today and this week and next week. But we are also really trying to think long term, and particularly where we have some federal COVID funding, we are doing outreach and we are doing testing and we are planning for vaccine and we're doing all of the work that needs to happen. But we're also really trying to think about how we use these investments to build systems that will give us a stronger public health system, that will give us better access to care, even in the years post-COVID. And so, I always like it when we have a chance to step back a little bit from the physical health and the cases, which of course remain the primary focus, to think about some of the larger pieces that we've been investing in. So I encourage you to check out that press conference if you're interested. But that means we're on at a different time. So let's go ahead and take a look at our data for today first. And you can start putting your questions into the box below. You can also put them either on Facebook or Twitter with the hashtag AskDrArwady. We do take your questions live, and if we don't get to them, we often will film them on the off days. So keep putting them in, and even if we don't get to it today, we will work on trying to get everybody's questions answered. And it's been a busy few days nationally from a COVID perspective, so I'm guessing we'll get some questions related to that. But let's look at our Chicago data just while people are having a chance to put questions in. So as always, you can go to chi.gov/COVID-, or for all things related to coronavirus in Chicago, chicago.gov/coronavirus. And this is our dashboard. So first, let's start with that positivity rate up here. This is our test positivity rate. You see it's at 4.3%, and it's been really stable in the 4.2, 4.3% range for a few weeks at this point. And I'm very pleased about that. It is below and remaining below that 5% threshold that we've really set as where we want to be as a city. Where you look at the regions across Illinois, there are 11 regions. The city of Chicago is its own region, actually, Region 11. And we have the second lowest percent positivity, test positivity of any region in the state. The only region that's lower is the region that includes Urbana-Champaign, where the University of Illinois is doing a lot of testing. And that is really, you know, in a good way, driving the positivity down for that region. But after that, we are second in the state. And I really am hopeful that we will be able to maintain that and hopefully even be able to see that percent positivity drop further. I also want to highlight, of course, our case numbers. So we're at a cumulative cases at this point of 82,039, and our 7-day rolling average is at 329. You'll note that is up. It's up, depending when you look on the day, like today, it's up 10% from where we were a week ago, where we were right at 300. And we don't like to see that number go up, but we look at it in the context of how much testing we're doing. And a good piece of news here in Chicago, which is part of why that percent positivity has come down for the tests very nicely, is that we actually, day after day after day, over the last couple of weeks, we've been breaking records now for how many tests are being done in Chicago. You can see this on this graph over here on the right, that our 7-day rolling average is now up over 9,000 tests. It's at 9,054 across 7 days, the highest it has been at any point during the outbreak. And in fact, if you come down here and you look at individual days, we've also had our first days where we're crossing 12,000 tests on a given day. So we look at the, how much the cases are going up and whether that's in proportion or out of proportion to the change in testing. So you can see our change in daily tests is up about 6%, where our change in cases is up 10%. So certainly keeping a close eye on all of this, but some good progress on testing. Where we look at our daily by demographic, you'll see again that actually our people tested here is also up 6%, the same as the cases are from the prior week. And deaths are stable here. Our person positivity still is at that sort of 7 to 8% range where it has been. As a reminder, that's when we only count everybody once. So if you've had a positive test, you've had a negative test, you only get counted one time in this, and that is the figure that we use to compare across neighborhoods, race, ethnicity groups, or gender or age. So overall, we are paying close attention and really in this stage where things are broadly remaining controlled and flat compared to what we are seeing around us. But I certainly do have a lot of concern about some neighboring states in particular. So let me actually do a quick update on the travel order too, and then we'll get to questions. So Tuesdays are our day for updating our emergency travel order. And as of today, it does contain 22 states and territories. We added Alaska, and we removed both Georgia and Texas. And for those of you who have been following along closely, Texas was able to come off the list because they had really a spike, mostly due to starting to count their probable cases, which are the cases that are diagnosed only with an antigen test as opposed to with the more traditional PCR test. And so given that it was primarily a testing difference that had driven that up, it's good to see that back down, and we did remove them this week. And then more relevance, I think, to folks here in Chicago is that Indiana is back on our warning list. And we have made it a practice all along here that for our neighboring states, and particularly for Indiana and Wisconsin, if They are getting above a point where they may be added to the quarantine list. Again, that's just it's a number based on the state that the state reports to the CDC. If they get above 15 cases per 100,000 population per day, as a rolling average, that is what gets you on the quarantine list. And Indiana right now is just above that point. They're at 16.4 average daily cases. And we are not putting Indiana on the quarantine list today, but if we don't see Indiana improve over the next week, unfortunately, they will likely have to be added. And I'm particularly concerned about Indiana because they have really moved ahead to what would be the equivalent of our phase 5 here, have lifted nearly all of the restrictions that have been in place and that have helped to control COVID. And I'm concerned about that. So my very strong ask will be that if Chicago residents are traveling to Indiana, even if they're not officially on the quarantine list, please, please be extra careful. As always, wear your mask, keep your social distance, do your hand washing, and know that we really do have concern and are hoping that Indiana will be able to see some improvements there. I also just wanted to note Wisconsin. I've been getting some asks from people about, is Wisconsin likely to come off soon? And unfortunately, Wisconsin, honestly, is having one of the worst outbreaks that I have seen in any state to date. Remember, 15 cases per 100,000 per day is our cutoff. Wisconsin right now is at 42.9 per 100,000 per day. So they are nearly 3 times the rate of cases that requires quarantine, and their percent positivity has been flirting with 20%. There have been days that they've been over 20%. Similarly, a lot of the restrictions that have been shown to work when an outbreak is in poor control are broadly not in place across Wisconsin. And so if you are a Chicago resident and you're traveling to Wisconsin, or you're from Wisconsin, unless it's for a work related, and there's details on the website if you need that, you are required to quarantine. And I would really ask people just to avoid that travel if you can. Iowa remains high concern. Missouri, a lot of our neighboring states are really not doing very well right now from a COVID perspective. So I can't control other states, but what all of us can control is whether we continue to practice the things that we know help keep ourselves, our families, our neighbors safe, and double down on the things that work. All right, so let's get some questions in here. All right. So at Estavivo on Twitter says, I've noticed our confirmed cases have been rising since the decision to loosen restrictions on 9/28, and then maybe jumped even quicker day to day after 10/1 when the pullback of restrictions went into effect. Was this expected? Okay, so good question. I'm glad you've been following along really closely in the data here. I like it when people are watching this closely. So it actually takes some time to see the effect of these changes in restrictions. Remember that if someone is infected with COVID-19, it can take up to 14 days for that infection to show itself. It takes at least usually 5 to 9 days, but it can take as long as 14 days. And so we actually don't expect to see changes related to changes in restriction right away when we make them. We're really more looking at what is out a couple of weeks later to understand what that impact has been. As I noted, we are seeing this increase in cases, but some of that, and actually I think the majority of it, is due to the increases in testing. And if we think about what is driving that, we know that the people diagnosed in Chicago, the 80,000 or so people who have been diagnosed with COVID-19, are only a small fraction of the people in Chicago who have had COVID-19. We know that there are many people who are asymptomatic or mildly symptomatic. We know that early on, where there was not widespread testing, there were people who had COVID and never got a test. And the estimates across the country have been that anywhere from 5 to 10 times the number of people that have been diagnosed have actually had COVID. And I think here in Chicago, based on what our mortality rate looks like and some other data, we're probably down near the lower end of that. But still, the lower end of that means, the number of people that have been diagnosed is a little bit less than 3% of Chicago residents. But I would estimate that somewhere probably in the 15 to 17% of Chicago residents have actually had COVID. And if you've been following some of the antibody test results, where nationally researchers have been looking at people who are getting dialysis or are giving blood and who are checking antibodies on those. Remember, antibody lets you know someone has been exposed to COVID, has recovered, and has mounted some immune response. Nationally, it's highly variable from state to state. There are states that still only about 1% of the residents have signs in their blood that they've had and recovered from COVID, whereas out in the New York, New Jersey area, it's more in the 23 to 25% range. Here in Illinois, it's been in sort of the 10, 11% range. I'd say we're a little higher than that here in Chicago, probably in the 15 to 18, maybe 20% range. So what this means is that as our testing numbers are going up, we're actually detecting more of the people who have had COVID, but perhaps previously would not have been detected. And so we look at it's part of why we look at not just the case numbers, but we look at that percent positivity. If you're seeing case numbers go up, and especially if that's being accompanied by increases in test positivity, you really are having a problem here. And I am watching both the test positivity and the person positivity really closely. We continue to also see at this point very good news in terms of hospitalizations, emergency department visits, some of those more serious outcomes, and our response infrastructure is good. But certainly, my mood rises and falls a little bit with our COVID cases every day, as I'm sure many of yours does. We're keeping a really close eye on this, and please know that if we start to see significant signs of concern, we won't hesitate to take action, but our goal here is to make sure that we are protecting everybody's health, and the best way to do that is by making sure everybody is doing the things that we know work. We continue to see most of our transmission in private settings, in households, in social gatherings, more than we are in some of the larger congregate and workplace settings. Okay. Bill Morton on Facebook says, Mayor Emanuel removed funding for a mental health facility in Rogers Park. How much is being invested in Rogers Park with this plan? So Rogers Park is definitely one of the community areas that has been invested in with this plan. I am not sure that I'm going to be able to give you the exact dollar amount, because it's not broken down just like that. But what I would do is refer you to the website, the CDPH website, chicago.gov/CDPH, and we are making sure that all of the information related to this announcement is up there. There are 32 different clinical sites that have been invested, and I know Rogers Park was one of them. Each of the community-based sites is receiving either $350,000 a year if it's part of a partnership organization, or $240,000 a year if it's a single organization. So that is what I can say off the top of my head, but I refer you to the website if you're interested in the details. And we will be making sure that that community areas are getting specific information so that you can easily look on a map and see what some of this expansion of services has been in your area. Okay. All right, we've got a question here. EW Baker1 on Twitter says, thanks for the updates. Do you feel confident a fast-tracked vaccine is safe, or is the timing of a COVID vaccine abnormal? What metrics do we need to feel confident it will be safe and effective universally? Okay, really good question. So My number one goal is to make sure that our conversations about the COVID vaccine remain absolutely based in the science of vaccines. We have 18 approved childhood vaccines that are safe and are effective, and they've all gone through the same process that is being used right now to test the many different versions of the COVID vaccine. So to your question, there's not just one vaccine that's being studied. There are literally dozens that are now in human trials, and there are 4 that are now in what are called phase 3 trials, which are the really large-scale, tens of thousands of people who are receiving a vaccine as part of a trial here in the US. And the part that is making this fast-tracked is mostly because, first and foremost, we have never, ever seen the world's medical researchers and scientists come together around one issue like this. This has literally impacted the whole world, and it has brought such major, health, deaths, but also economic implications for the world, that the desire to move toward an effective vaccine has never been stronger. And companies, researchers, governments around the world have been investing billions of dollars to make sure that the researchers have the resources they need to get the science done appropriately. So the fastest a vaccine has ever previously sort of gone through the whole process was the mumps vaccine, and that was about 4 years. 4 years is not going to work for COVID. So one of the other things that's happened is that there's been work to make sure that a lot of the manufacturing processes around the vaccine, which are, to be honest, almost as much or maybe just as much of a challenge as the actual sort of scientific production of the vaccine, a lot of that work has been happening simultaneously with the clinical trials. So the way a vaccine normally works is you do your phase 1 trial. You make sure that it's, first you do a lot of pre-human work. You make sure that a vaccine looks like it's effective in the laboratory or in an animal model. That is typically many years of work. Luckily, we had a sort of a head start on this one because there had been a lot of work already done thinking about potential vaccines for MERS, which is another coronavirus, or for SARS, which is another coronavirus. And there had been some work recently with the Ebola vaccine and others. So we kind of had a head start in that sort of pre-human testing zone, which a lot of scientists have been able to build on. But then once you get into human testing, that phase 1 is a very important. It's just given to a very small number of volunteers, and you're looking to make sure that this is safe, and you're trying to figure out what dosing may be needed. If that looks good, then typically you raise additional money, you do additional planning, you move to phase 2. Phase 2 is when, instead of giving it to maybe a few dozen volunteers, you give it to 100, a few hundred volunteers. You start expanding it out. You're looking not just for safety, but making sure that it's looking like it's effective in terms of the response that you can see in the blood from somebody's immune system. And then typically, if that looks good, then you go to the FDA and you look at the data, you get additional funding, because the decision to move to a phase 3 trial, which is when we're talking tens of thousands of people getting the vaccine, and half of the group gets the vaccine that is being tested, and the other half gets a placebo, does not get the vaccine, gets an injection. The person actually does not know whether they've received the vaccine trial or a placebo, and the doctor who is giving it does not know. And we follow forward these two groups of people. And we need to follow them forward for enough time to make sure that we're not seeing unexpected side effects, and that the immune response looks like it's going to be relatively long-lasting. It's not a lot of good to anybody to develop a vaccine that's good for 1 month or 2 months or 2 months or 3 months. We want to have a vaccine that ideally lasts, multiple years, if not sort of indefinitely. But you can't know that for sure in the early stages of a vaccine trial. So normally, all of these phases happen with a lot of time in between them, and then only if you get a phase 3 trial done and it's successful, there's a very long process, looking at this, and only then do you again say, okay, now time to raise a lot of money, make major investments, and figure out how are we going to manufacture this. And then after you figure out how to manufacture it, you actually do the production of it, you figure out the distribution, you figure out the planning. So here, the main thing that's been sped up is the work on this manufacturing. These vaccines that are right now in phase 3 trials are also right now being manufactured. If those phase 3 trials turn out to not show that the vaccine is first and foremost safe, and secondly, effective, all of that billions of dollars that have been put into producing that vaccine will have, quote, gone to waste because we won't use that vaccine. But you will have saved potentially years in the process, and given the huge impact this has had on human health around the world, that investment is worth it. So we will be following, to kind of get to the last part of the question, what metrics will we be following? How will we know that it's safe and effective? So there will be a lot of data put out around these trials, and some of you may have been following the FDA. There's been some things in the news about the FDA releasing some stricter coronavirus guidelines, and there's some conversations with the White House. I am very confident that that the appropriate scientific procedures will be used to approve these vaccines, because there are a lot of checks and balances in this program. There are advisory committees, of people who are not funded by the pharmaceutical company or by the government. Their only role is to sort of be an advisory committee. There's something called the Data Safety Monitoring Board that is able to look at the data during the trial, identify if it seems like it's being effective. There are a lot of procedures that are already in place. But what we want to do here in Chicago and in Illinois is actually create sort of our local version of a kind of a vaccine scientific committee or advisory committee that will look at the data out of these trials, which will all be publicly available. You'll be able to look at it too. I won't be taking a vaccine until I have seen this data, and I'm confident that all of the appropriate safety and efficacy things that need to happen for me to be able to recommend a vaccine or take one myself have been followed. But I don't want to be the only voice on this. I want to actually bring in other local researchers, scientists, doctors who can look at the scientific evidence around this, and collectively we can say, yes, at this point we feel like this vaccine is good for recommendation for use here in Chicago and in Illinois. And then there will be a lot of work, obviously, partnering with community-based organizations and many others to make sure that sober, honest messaging is getting out about this vaccine. We cannot allow the conversation around the vaccine to be politicized in the way that, unfortunately, I think the conversation around masks has been politicized. And I will be doing everything that I can. I know that the Illinois Department of Public Health will be doing everything that it can. We all here in Illinois feel very strongly about making sure that when we're recommending a vaccine, all of the appropriate safety and efficacy science has been done. The experts have had a chance to look at the data nationally and our own folks here, I will take a vaccine when I see that appropriate oversight has been in place, and I'll be making that recommendation to all of you. Okay, so Karen Pearson Clopton on Facebook is asking, can you test positive more than twice for COVID? Okay, so you can. A lot of this would depend, and I don't know exactly in your question here. So first of all, if somebody has a test multiple times during their COVID infection, that of course would show up multiple times as a positive test. Where we see this particularly being important is the fact that the main test that we use, the diagnostic PCR test, again, that's a nose or a mouth swab. It's the one we've been using all along. That one, when it's positive, it's positive. It's found the RNA for the virus itself, and we're confident that this person has COVID-19. It's such a sensitive test, though, that it can can actually stay positive for a long time, even after someone is no longer infectious or spreading COVID. So if you might recall that people who have been diagnosed with COVID need to stay isolated for a minimum of those 10 days, and the last 3 days their symptoms need to have resolved. No more symptoms, no more fever, feeling good. And but it is possible that if you test somebody, in fact likely that if you test someone at the end of that 10 days, sometimes even for some time thereafter, you may still pick up traces of that DNA when you do the test. But it has not been shown that people continue to spread COVID as long as they've recovered in a symptomatic way. That in fact you can pick up sort of dead pieces of DNA or DNA that does not make somebody continue to be infectious. So that's usually, if that was what your question, the most common place that we see it. The other question where this sometimes comes up is, can someone be reinfected with COVID? And we have seen people be reinfected with COVID, but not frequently. There have been a couple of really good specific examples of this where people were able to check the fingerprint, the genetic RNA fingerprint of the virus from the first time someone was infected compared to the second time they were infected, and see that yes, in fact, these were slightly different versions of coronavirus, and you know that it's a second infection. But that is thought to be very rare. However, it's part of why we recommend even people who have recovered from COVID. We have a lot of questions still about how long that immunity may last, how complete it is. There seem to be a lot of differences in that based on age, based on even how sick somebody may have been with COVID. So really, even if you're someone who has recovered, you need to be wearing the mask and doing the social distancing and all of the things that other people in Chicago are doing. Kelly Keegan Diaz from Facebook is asking, are masks required inside a gym? In the city of Chicago, masks are required inside of a gym. If you're swimming, you can have them off. But if you are, and in the swimming, there has to be the appropriate social distancing. But really, besides that, if you're in a gym and working out in Chicago, you do need to have a mask on. And I'll tell you, that is based not just on evidence that we've seen from around the world, although we have certainly seen evidence from around the world about this, but it's also from some outbreaks that we've seen here in Chicago. We had an example a few weeks back of sort of a gym situation where people were getting together to exercise and didn't necessarily realize that in Chicago it is a requirement to have a mask on if you're in a group exercise setting or if you're in a gym setting. And we saw quite a bit of spread in that setting. People are, you're exercising hard, you're breathing hard. There's probably more COVID that you're exhaling when you are exercising. And when we asked people who were in this exercise group, who was consistently wearing a mask versus who was less consistently wearing a mask, we definitely found that wearing the mask was protective as well, even though we mostly think about the mask as helping to protect others. So absolutely, even as we've been wanting to and have in fact been able to relax some of the capacity restrictions that are in place. For example, with our most recent relaxation, we let indoor fitness classes move from a max of 10 to a max of 15 people. Masks are required here in Chicago. Good question. Okay. Oh, we've only got 5 minutes left. This has gone very quickly today. Got a question. Can you address the CDC guidance? Why do you think there's still ongoing conversation about airborne transmission? So I think that'll be our last quick question, and maybe we'll pick that up again on Thursday because it's part of a larger conversation. So, there's been a big ongoing conversation for months now about COVID and airborne transmission. And I think some of this is because the term airborne actually means different things to different people. There's the way that we use it in general speak, which is, can COVID be aerosolized? When someone is coughing or speaking or singing or breathing hard from exercise, is it possible for small amounts of COVID to become an aerosol, to be in the air? And that is definitely possible. But airborne in sort of a hospital setting has, an infection control setting, has sort of a very different meaning. And so it's part of, I think, why there's been some back and forth. But the bottom line is that we know at this point that it is definitely possible for COVID to be in the air. It's possible for it to move even, beyond that 6 feet. But most of it continues to be really driven by the droplet transmission. That seems really clear to me, and I think to the majority of scientists around the world. And let me tell you from a practical standpoint how it's most important for me when I'm thinking about this, and how I want you to think about it, or I'd suggest you think about it. So there are diseases that are airborne in a way that we see, if you are even in the room with someone who has had one of these very infectious airborne diseases, like measles is the primary example. I've worked on measles outbreaks here in Cook County, in Liberia during the Ebola outbreak when they stopped doing measles vaccines, they were having measles outbreaks. And that is so infectious in an airborne way that really, we pretty much expect that if you are in the room and you are not immune, there's a good chance you will get measles, and we've seen that in daycares and other settings. And on average, someone with measles will spread measles to an average of 18 other people. It's something called the R, the reproductive number, and that is a very infectious virus. COVID behaves in how easily it is spread in most situations much more like a droplet transmission kind of virus. So the average number of people that someone with COVID spreads to is 2 to 3 in the absence of masks or social distancing or any of this. And then with the masks, the social distancing, all of the public health precautions that are in place, that average reproductive number of how many people will someone spread to, the goal is to get that down under 1, meaning that on average, every person with COVID spreads to less than one other person on average. That's what brings your curve down. That's what helps keep your outbreak in control. And, frankly, the fact that we've been able to see really around the world the ability to control outbreaks with things like mask wearing, social distancing, hand washing, all of these materials, broadly been able to keep the virus in control is one of the reasons that, I continue to keep my primary focus on those behaviors, which are the most important for that close range interaction. I think we're continuing to learn about the space related to aerosolized COVID, and certainly conversations about, what can we do to improve even further as we're inside related to, the possibility of transmission. But what I don't want people to think is, it's airborne, this means I need to change, the masking and the social, all the things that I've been doing. No, those are the most important still in terms of helping to prevent COVID. And I think we're continuing to learn about other ways in which we can make indoor settings even safer. So, all right, I think we're about at time. We can pick maybe a little bit more up on that on Thursday if people are interested. But thank you for joining at our unusual time today. Just for a little bit of good news or reminders. So first of all, we're still finishing up the census, and I know I've been talking about it for months, but we only have until Halloween, October 31st, and we really need folks, if you've not done it or you know anybody who hasn't done it, to fill out the census. My2020census.gov. It is how Chicago gets representation in Congress, and most importantly, it's how we get funding. If we undercount Chicago, the Chicago Department of Public Health gets less funding to be able to control COVID, control whatever disease may come next, and to keep Chicago as healthy as it can be. And that is replicated across schools, it is replicated across roads and bridges and all the things that help us really build a successful, thriving city. If we don't do a good job of counting people here in Chicago, we don't get our fair share. So please, there's just a few weeks left, and I know everybody's really focused on the upcoming election as am I, but around, along with thinking about registering for vote, doing your voting by mail if you're concerned about COVID, we could talk some more about that. Please make sure that you and everybody you know has completed your census. So I think with that, if you missed the press conference we did last week about Halloween, there were costumes involved. You can go to chicago.halloweek.org. That's Halloweek, because there will be a week of COVID-safe activities around Chicago, ways to have fun but try to keep the risk as low as we can. So thanks for joining. We'll be back on Thursday at our normal time of 11 a.m. Be safe, Chicago.